I would be discussing a very common gynecologic disease called pelvic inflammatory disease. It is a disease of reproductive age, especially menstruating women younger than age 25 years, who have a multiple sex partner and don't use contraception in an area with a high prevalence of sexually transmitted infection. Most patients present with lower abdominal pain, abnormal vaginal discharge and painful sexual intercourse. Definition: pelvic inflammatory disease, an upper female genital tracts infection characterized by inflammation and infection arising from the endocervix leading to endometritis, inflammation of the uterus lining, salpingitis, oophorytis, and pelvic peritonitis. Women genital tracts refer to your reproductive organs or structures located at the lower part of your abdomen, tummy, and this includes the vagina, cervix, uterus, the so-called womb, fallopian tube and the ovaries. All these are all connected directly with each other starting from outside as vagina and open into the abdominal cavity via the fallopian tubes. This explains why infection can ascend, travel, from the vagina to the uterus and enter the abdominal cavity. Genital tracts are divided into upper and lower tracts. Both are susceptible to infections, and infection from lower to upper tracts is more common than upper to lower tracts. The lower tracts are the vaginal and the cervix, endocervix, while the upper tracts include the uterus, fallopian tubes and the ovaries. Organisms which are implicated in PID include Chlamydia trachomatis and is the predominant sexually transmitted organism associated with pelvic inflammatory disease. Others include Neisseria gonorrhoeae, Haemophilus influenzae est. These have made pelvic inflammatory disease a polymicrobial infection. There are risk factors that predispose you to pelvic inflammatory disease, and these are outlined below. Multiple sexual partners and young age at first intercourse. However, PID is very low in women who are not sexually active and those with total abdominal hysterectomy. Infected sperm from partner who has sexually transmitted infection. History of previous sexually transmitted infection in either partner. History of sexual abuse, most especially if the culprit has infection. Frequent vaginal douching, very common among the ladies of nowadays. Uterine curettage and inadequate treatment resulting from abortion, miscarriage. Contraception such as intrauterine, copper T, in family planning. Excessive usage of antibiotics mostly for sexually transmitted infection. This disrupts the balance of endogenous flora, protective bacteria that resides within the vagina, in the lower genital tract, causing normally non-pathogenic organisms to overgrow and ascend. Bilateral tubal ligation doesn't protect against pelvic inflammatory disease. What happens in pelvic inflammatory disease? The major process is by ascending, upward spreading, of infection through the vagina to the uterus and fallopian tubes via I. Acquisition of vaginal and cervical infections that are often sexually transmitted. E. Direct ascent of the microorganisms from vagina or cervix to the upper genital tract leading to infection and inflammation of the involved structures. Opening of the cervix during menstruation and retrograde menstrual flow facilitate ascending of microbes. Intercourse may contribute to the ascent of the infection through rhythmic uterine contraction occurring during orgasm, while bacteria may also be carried along with sperm into the uterus and fallopian tubes. Disruption in the balance of endogenous flora, protective bacteria that resides within the vagina, by excessive usage of antibiotics in the lower genital tract, causing normally non-pathogenic organism to overgrow and ascend. What are the signs, symptoms and diagnosis of pelvic inflammatory disease? The diagnosis of pelvic inflammatory disease is predominantly historical, i.e. patient complaints, and clinical, i.e. doctors' finding on examination. Therefore, I will advise you to pay attention to the signs and symptoms. Lower abdominal pain, the most common presenting complaint, which is dull aching or cramps, bilateral and constant. In a severe case, fever with temperature greater than 38, nausea and vomiting with severe pelvic and abdominal pain, which begins a few days after the onset of last menstruation, worsened by cervical motion, exercise and coitus. Abnormal vaginal discharge in 75% of case. Dyspareunia, pain during sex. Vaginal bleeding after sex, post-coital, in 40% of cases. Rebound lower abdominal tenderness and involuntary guarding. These are signs elicited by your doctor to make a diagnosis of pelvic inflammatory disease. An ultrasound scan, precisely pelvic, transvaginal scan, is the most appropriate form of scan to do and shows a fluid-fill pouch of Douglas's. Full blood count, complete blood count shows elevated white cells that signify infections. High vaginal swab, HVS, a test of microscopy and sensitivity done via culture of samples taken from the vaginal to identify culprit organisms and drugs of choice based on sensitivity. There are complications that can arise from pelvic inflammatory disease. These includes chronic pelvic pain and ectopic pregnancy, infertility, a result of fallopian tube blockage and implantation failure. Treatment of pelvic inflammatory disease. The treatment depends on the severity, complications and other associated genital infections including the unexpected fungi infections which most of the time is seen on HVS. The treatment will also go a long way if culture can be done to detect the likely culprit organisms and possible sensitive antibiotics. From my own experience, poor treatment of this infection and exclusion of one of the partners causes recurrence of this infection most times. For proper management of mild to moderate infection, do a combination of medications depending on culture and sensitivity with pelvic scan. However, use the following combination in case nil good response. Tab doxycycline 100 mg twice daily plus tab metronidazole 400 mg twice daily for 7 to 14 days. Tab ofloxacin 400 mg daily plus metronidazole 400 mg. I will not give more than this combination, because microscopic, culture and sensitivity from HVS outline the most appropriate medications to tackle the infection. These investigations when done usually reveal most appropriate and sensitive injections and tablets that can be combined to combat this infections. Even changing the whole pattern if tests show resistance to drugs may be warranted, meaning after the first trial and no improvement see your physician to prevent resistance. Your partner must be treated for you to gain full control of the disease. Bear in mind that different doctors treat patients differently and medications differ in individual handlers. Thanks.